Well, a warm welcome to this talk, and regular viewers of this channel may well remember Dr. Nigel Eccles. Welcome back, Nigel. Thank you for coming.
Thank you for inviting me.
Now, Dr. Eccles, as you might remember, is a physician. He's also got a doctorate in pharmacology, and he's also the natural doctor, which is something I take a particular interest in because he likes to optimize health in order to prevent disease. And there's a lot of fairly simple things we can do, low-cost things we can do to improve health and prevent disease. Is that roughly what your philosophy is, Nigel, on this?
It is. I think that the thing that runs through a lot of what I do in my practice is focused on earlier detection of disease process. So in other words, not waiting till a disease is established, but identify physiological process which might be a precursor of a disease, and then fix the physiological imbalance before it moves into, a clinical problem. So that moves through a lot of what I do, a lot of prevention, early detection, and then changing the physiology so that you reduce risk in the longer term.
Mm-hmm. And today we want to focus particularly on breast health and particularly on breast cancer. Mm-hmm. Just before we do that, could you differentiate, please, between a physiological change in a tissue and an anatomical, pathological change in a tissue?
Yes. So a pathological change is really when something is entering the disease diagnosis arena. So, all of the diseases that we put labels on, really, that's a diagnosis. So if we're talking about cancer or breast cancer, we are able to sample cells, usually with a biopsy, which then pathologically represents a disease process. Whereas a physiological change is if you look, is kind of going back in time before the diagnosis. So changes such, for example, changes like inflammation in a tissue might be a precursor for that tissue having something malign happen later on. So if that inflammatory change isn't checked, then it could lead to a diagnosis, something pathological. We could argue the same for, for example, the balance of hormones, since we're talking about breast, let's say the balance of hormones in breast tissue. An imbalance of hormones in the breast tissue isn't a diagnosis, but it may represent a physiological disturbance which might lead to a greater risk of a diagnosis if left unchecked. So, for example, if you've got too much estrogen in the breast compared to the amount of progesterone, those are the two main female hormones, there is a consensus that might lead to an increased risk of breast cancer. So if you were able to detect that imbalance between those two hormones sooner and then correct that imbalance, you could argue that would lead over time to less of a reduced risk of a cancerous change in that breast. So there's the difference, is measuring things that impact physiology versus actual measuring diseased tissue, and I think that's what we're talking about here.
So it sounds like to me it's a much better idea to correct an abnormal physiological change rather than wait for something that a pathologist could see under his microscope slide. And that's right. How does this relate to breast analysis and thermography? Well,
it's the fact that from a mammographic perspective, so in other words, what are we looking for in a mammogram? We're looking for something, a lesion, a lump, which is big enough to block enough X-rays to show on the mammogram plate. Now we think that by the time something is big enough, it usually has to have reached the size of a small grape, or 1 centimeter in size approximately. The problem with that is that by that stage it represents about 500 million cancer cells. So you're potentially waiting for a period, depending on the aggressiveness of a cancer, you could be waiting 6 to 10 years for it to reach that size before you detect it on a mammogram. Now, let me just explain further why this is a big problem. We know from wide excision biopsies, so where on a mammogram there appears to be a single lump. When you take 4 centimeters of tumor, wide excision, to remove that lump, in 2/3 of cases, and this has been published, 2/3 of those cases you see multifocal deposits of tumor in the surrounding tissue. So what you thought was single tumor on a mammogram isn't in 2/3 of cases. Now that therefore is, in my book, that's too late detection. You're detecting the disease when it's really established itself, and often when it's a cancer that's spreading outside the focal area. So the difference with thermography, we're not looking for structural change. We're looking for heat changes in the breast by using highly sensitive infrared cameras, which basically detect heat coming from the body surface, in this case the breast tissue. And we know early cancers generate heat. We know that. We've known it for a long time. The consensus is that these heat changes precede the structural changes. Now, there's another side to this. We're not just looking for heat changes in a properly done thermogram. We're looking for heat changes. We're looking for abnormal blood vessel patterns, because you're able to see those on a thermogram. And you're also looking, and this should be the case on the way thermography is done everywhere, you should also look for resistance to cooling. So you're looking for 3 things: heat changes, tissue that doesn't cool, and that's because new blood vessels supplying a cancer don't have a normal nervous system innervation, so they don't cool normally when you challenge them and when you stress them, so they don't go into vasoconstriction. So hot areas can tend to remain hot, and then abnormal blood vessels suggesting a process of angiogenesis, where you've got these abnormal blood vessels nurturing the growth of a tumor. So we're looking for those 3 things on a properly conducted thermogram. All of those things can precede the structural changes that we see on a mammogram. So hence, I believe that that using thermography, if done correctly, can identify some of these changes much sooner than a mammogram, which is the gold standard of screening, as you know. So, and I've been arguing that from 2013, when I started to look into this, started to offer thermography. But it's important to understand the difference between those 2 things. You know, one is a breast health screening tool, i.e. a thermography, and whereas mammography is a breast cancer screening tool. And I think if we're going to make a difference to the incidence of cancer, what we have to do is start to detect changes in the breast earlier, so that we then have a better opportunity to do something to arrest that process in its tracks.
Mm-hmm. Now, if you do notice what we might call a heterogeneous breast in terms of thermography, with cold patches and warm patches, mm-hmm. The warm patches, as you've said, by those 3 criteria, indicate there could be some pathophysiological change which could be leading on to a malignant change in the future. Mm-hmm. What the heck do you do about it? That's the
$100,000 question, and I'll tell you what I do about it based on our experience. So it's important to say that not all thermal changes represent cancerous changes. Yeah. So when you see temperature in one breast and not in the other, it doesn't necessarily mean that is a cancerous change. It can just be inflammation. There may be some blocked lymphatics. It might be something transient, but the problem with thermography is not so much a single thermogram, but whether or not that temperature change remains persistent over time. And some of the early studies, some big studies in the 80s actually, what they did is they looked they identified women with abnormal thermograms and then followed a cohort of women that had abnormal thermograms over time, and found that over a 5-year period there would be a 40% increase in diagnosis of breast cancers in those women who had serially abnormal thermograms. So the thermograms that remained hot over time definitely represent an increased risk position. And so that's the way to correctly look at an abnormal thermogram. Not that it equals a diagnosis, but that it represents, if sustained, an increased risk over time. So coming back to your question, John, what do we do about it? Well, when I first started doing this, and we had women who did have abnormal thermograms, we started studying them nutritionally to see were there any nutritional imbalances in these women that could be predisposing their breast tissue to abnormalities. So we measured things like their vitamin D level, their iodine level, how they were metabolizing their estrogens to see if there was a greater proportion of toxic, damaging estrogens to non-toxic estrogens. And all women will break down estrogens in either a toxic or a non-toxic pathway, but if the proportion is in favor of toxic, that could damage breast tissue or uterus tissue, so hormone-sensitive tissue, basically. So we were looking for that, and we looked for omega fatty acid balance as well. And what I found is that women who had abnormal thermograms almost always had at least 2 imbalances out of those 4 things that we measured. So what I set about doing then was replacing or rebalancing some of those common deficiencies in all women who had abnormal thermograms. And what I found that over a 6-month period, by just correcting those nutrient imbalances, more than 80% of abnormal thermograms would either return to normal or be normalizing at 6 months. So what I believe is possible is that even if you do have an increased risk, which we're identifying with thermography, it is entirely possible to change that risk over a period as short of 6 months. In my clinical experience, that's what we've been able to do.
Really quite impressive. And vitamin D and iodine, of course, are common deficiencies.
Common.
And of course, we can't prescribe for everyone because we have to prescribe on an individual basis. But I think it's fair to say that everyone, male or female, should consider their vitamin D status because it's often very low.
Absolutely.
And their iodine status. Now, of course, we know that people who live far away from the sea tend to be short of iodine, and we get things like Derbyshire neck, and thankfully no longer in Derbyshire, but in Switzerland and in the highlands in Africa it's quite common. But a lot of us don't get a lot of iodine in the diet, unlike Japan, for example, where a lot of iodine in seaweed.
Correct.
And my understanding is that the incidence and prevalence of breast cancer in Japan is way lower.
It's one of the lowest. It's one of the lowest. That's right.
Yeah, than in the United States, for example, or the United Kingdom.
Iceland similarly, by the way. Iceland also low incidence of breast cancer and greater intakes of iodine.
Interesting. I didn't know that. And what I was surprised doing some preparation for this talk was just how high kelps are, for example, in iodine, and we simply don't eat them in our society.
We don't eat it, and we took iodine out of food processing because we used to use iodine in bread making. We don't anymore. In fact, it's worse. We use bromide, and bromide is an iodine antagonist, so it's a double whammy. And we used to feed cattle fish meal, which we don't anymore, and of course the milk, we were getting iodine in milk because of that. But so we've taken it out of the food chain. So I think it's one of the things that to my reading, according to the science, is really important for breast health. It's really important for maintenance of healthy breast tissue. And we don't really understand exactly how it's doing that, but certainly there does seem to be an association between low iodine and breast cancer risk. And you see it in those sort of population studies where you can almost correlate, low iodine to increased risk of breast cancer.
And of course, in the past, doctors have thought, well, this patient hasn't got rickets, therefore they're not short of vitamin D. This patient hasn't got a goiter, a swelling in the thyroid gland,
That's right.
therefore they're not short of iodine. But
No.
that's such a, the difference between an overt deficiency in something that's known about to an optimized nutrition.
And
we know that these
yes.
things are involved in so many aspects of health, as you've said before.
Yeah, yeah. And as you're rightly pointing out there, evidence of a diagnosis as opposed to evidence of a deficiency, which could lead to a diagnosis if left unchecked. And I think we don't do that well in mainstream medicine, I have to say. We often detect too late. So what we're saying about mammograms detecting late, it runs, unfortunately, runs through a lot of medicine, is that we're often detecting, we're measuring things, we're diagnosing, yes, and we're very good at doing that. But what we're not doing is is measuring early enough and picking up those imbalances that would lead to the diagnosis. And that's where I think, this arena of functional medicine, as it's now being called, has an advantage in terms of, prevention. And we're really applying a functional medicine approach to breast health. That's what I'm doing in my clinic.
So I feel very comfortable advising everyone to consider their vitamin D status and consider their iodine status. We can't really go further than that, but you need to think about that. The omega-3s, obviously we're talking about fish. And I think what a lot of people don't realise is that fish don't actually make the omega-3s. They get them from the plants that they ingest.
That's right.
So,
yes.
Exactly. I really think we need to be looking at more marine phytoplankton. But in the meantime, we can eat oily fish ideally. Any other foods for omega-3? I'm thinking of things like flax seeds, walnuts.
Flax seeds, chia, are the sort of common ones. There's another one that's gone out of my head. Oh, hemp seeds as well, of course.
Seeds, yeah.
So they're all rich. There's one that is also particularly high, a plant source which is particularly high, other than algae source, which you're rightly pointing out. There's one called echium seed, echium, E-C-H-I-U-M. Echium seed oil is quite high in long-chain omega-3s, so that's also a very good source of omega-3s in people who don't want to take a fish source.
So omega-3, so these things are very low tech, aren't they? Thinking about vitamin D, thinking about iodine, thinking about omega-3 fatty acids. I suspect it's more of a medical intervention, though, to reduce estrogen or increase progesterone, which would be ideal. How do you go about optimizing that ratio?
Well, it's one of my areas of expertise, John. I mean, I do a lot of hormone work in my clinic, and I opt to use the body identical hormones. I don't use synthetic forms of hormones because it's become very obvious from the science now that the main problem with hormones and breast cancer risk is the combination of synthetic progesterone with estrogen. And this was published in 2005, International Journal of Cancer, where they studied over 70,000 women, and they looked at incidence of cancers across different types of hormone replacement. And this has since been confirmed, by the way, with other studies, that when you combine estrogen with a synthetic form of progesterone, you see an increased risk of breast cancers, increased risk of clots. But when you combine estrogen with natural micronized progesterone, you don't see any increased risk of breast cancer, nor do you see any increased risk of clots. So we've known, even since then, 2005, that it's the form of hormones that are important. So the balance between estrogen and progesterone, yes, is important, but it's also important to, where possible, stick to a natural hormone replacement where you're replacing natural progesterone with preferably a natural estrogen, because if you do that, there is no associated increased risk of breast cancer, and that's been demonstrated. So because I do hormone work, I routinely measure blood levels of the hormones, particularly in perimenopausal or menopausal women. They're the ones who most commonly come to see me because most of them are symptomatic. But the other side to it is something I alluded to before, John. Not just the hormone levels themselves, but also the way a woman is metabolizing her estrogen could have impact on her risk. So if she's producing a lot of these 16 4-hydroxyestrogens rather than the safe 2-hydroxyestrogens, and the balance is tipped that way, that's a woman who potentially is damaging her breast tissue more. The good news is, by just increasing their intake of cruciferous vegetables, so broccoli, kale, cabbage, cauliflower, Brussels sprouts, watercress, that family of crucifers have the ability to switch a woman from a toxic estrogen producer to a non-toxic producer. Therefore, you're neutralizing the toxic estrogens. That, for me, means another way of reducing risk of damage to breast tissue in a woman that has that genetic profile, because that's what it is. Her genetic makeup is making her produce, more of these toxic estrogens than the non-toxic.
So what I think you've said there, Nigel, is that there's genetic factors that every woman has, and indeed men have the same with testosterone.
Yes.
But women have this, so they produce different, it's still estrogen, but it's like different types, slightly different types of estrogen.
Different waste products, different waste forms of estrogen because of the way it's broken down in the body.
The metabolic breakdown products.
Yes, that's right.
And but that can be greatly increased by taking broccoli, kale, sprouts, and cruciform vegetables.
That's one of the ways of neutralizing some of these toxic estrogens.
Wow, that's incredible. So
and that's an example of nutrigenomics, where you see if you have a gene, and this is the other thing that I think a lot of functional doctors are talking about more now, is the fact that even if you have a genetic risk, it doesn't mean you're a sitting duck, because genes are maybe the loaded gun, but you have to pull the trigger, and it's the environment that surrounds the gene that is important for whether that gene expresses itself or not. So it's very empowering for people to know that even if there is a family history of breast cancer, there are things that you can do to neutralize that risk, and those things reside in lifestyle and the sort of nutrients that you can put in on a daily basis, in my experience.
The natural progesterone and estrogen that you are able to prescribe, is this available for general practitioners to prescribe?
It is. There are licensed forms of these. Estrogel is estradiol, which is the main active estrogen, and utrogestan is the main is natural micronized progesterone. So all these natural forms of hormones can be prescribed by all GPs. In my book, should be. That's the way all HRT should be given to women, so that their risks aren't increased over time. Then we don't need to get so twitchy about taking a woman off HRT after 5 years if she's getting the hormones in that form.
Yeah, absolutely. So we've got some very simple things here. We've got the vitamin D, the iodine, the green vegetables, and the omega-3 fatty acids, and then the only thing really that you would need a doctor for is the
hormones. Yes, if you need hormones, that's right. That's right. That requires a prescription.
Yeah.
So yes, that would require a doctor's intervention there.
Mm-hmm. We know that breast cancer becomes more common as women age. I would guess the peak time for diagnosis is around about late 60s. Is it something like that?
Yes, it's 2/3 of cancers are in women above 50.
Yeah.
But that means 1/3 are being diagnosed under 50. So it's definitely as we age, it gets more prevalent for sure.
Indeed. So do you see more of these thermal changes in the breast as women age?
No, not necessarily. No. It's a good question, that, John. And we've been collecting data from, as I say, 2014. But you might think that a lot of women have thermal changes in their breasts, but they don't actually. It's only in our cohort of people we screened, you only really see abnormal thermograms, I would say, certainly in less than 20% and maybe even less than 10%. So most women who come for a thermogram have a normal thermogram, which is good. In my book, that means they have healthy breast tissue. we still talk about what they can do to keep it that way and prevent. And that's the empowering part of the message is, look, normal, let's keep it that way. This is what you need to do. So tick those boxes, and then we keep your risk low. So I think that's part of the message of thermography as well. It's yes, doing the screen, but what can you do proactively to reduce your risk in the longer term? And for me, that's proper preventative medicine.
Now, of course, we can't prescribe on this channel, so please don't do anything or take anything as a result of what we say. But purely out of academic interest, Nigel, what sort of doses of vitamin D do you often prescribe?
Very often 4,000 or 5,000 units of D3 daily, together with vitamin K2 in the MK7 form. This is very important because there is only one toxic effect of vitamin D that's been described, and that's this rogue calcification that you can get. Arteries, stones, you don't want that. Taking K2 along with vitamin D3 ensures that all the calcium stays in the bone and doesn't go anywhere else. So it's a really simple way of making these higher doses of vitamin C, 4,000 or 5,000 units, safe.
Vitamin D, yeah. And what? So 4,000 units of
4,000 or 5,000, yes, and international units of D3, yeah. Is what I'd routinely recommend. It's not really a prescription, but what I'd routinely recommend, John. Yeah. And the other thing to say is I'm a bit of a stickler with this one. All people who come to me, I always measure their vitamin D in their blood. And the magic number is 100 nanomoles per litre in UK units, 50 nanograms per mil in US units. Big study 2016. This is important for everybody to know. Big study showed that when you correlate blood vitamin D levels against incidence of cancers, when you get to 100 nanomoles per litre or 50 nanograms per mil, you see a sharp drop-off in the incidence of all cancers, not just breast. So the empowering message to everybody, male and female, is that if you can keep your vitamin D above 100, that magic 100, by just doing that, you're going to reduce your risk of any cancer, not just breast cancer.
Unfortunately, my GP won't test for vitamin D levels, but I do take that 4,000 and get some exposure as well.
Yeah.
So it's about 100. So about 100 nanograms or 125 nanograms of vitamin D, and about 100 not nanograms, micrograms. Sorry, 100 to 125 micrograms of vitamin D, and about 100 micrograms of K2. Is that roughly the dose we should be thinking?
My rule of thumb with K2 is for every 1,000 units of D3, between 50 and 100 micrograms mcg of K2.
Right.
Yeah. So that's roughly, and there's no absolute definitive on this, but the consensus, looking at the vitamin D experts and K2 experts, they said really between 50 and 100 micrograms K2 per 1,000 units of D3 that you take is about right.
Yeah. And of course the K2 normally comes from fermented food. So if you're living in Japan and you're eating lots of natto, or if you're living in Korea and eating huge amounts of kimchi, you may not need supplementary K2.
That's
but in the UK, we don't eat, or if you're living in the woods in Germany and eating huge amounts of sauerkraut.
Exactly.
But unfortunately, we just don't get
it's fermented
food. We don't get the fermented foods.
No, that's right. That's absolutely right.
Now, iodine, I would imagine that what sort of, if someone's very low in iodine, what sort of doses would we need to top them up, to top the thyroid gland up and to spill some over into the blood?
Okay, so it's generally thought that, and these doses are higher than the sort of routine recommendation, but it's generally thought, if you look at the literature, that it takes about 3 milligrams of iodine to saturate the thyroid. So in other words, to give the thyroid plenty to be making thyroid hormones. But in order to get the extra thyroid effects in the other tissues, you need to go above that. So
this is 3 milligrams per how often?
Daily. So 3 milligrams daily. Now, if you look at the average intake in the Japanese from their diet, they routinely take in somewhere average around 12, 13 milligrams daily.
Wow.
So that's a heck of a lot more than we take in the
Wow.
West. So as a general guide, and we know that they have reduced risk of breast cancer. So as a general guide, so that you're not sort of going into toxic ranges of iodine. Common sense would tell you that if you take somewhere between 3 milligrams and 12 milligrams daily, you'd only be doing what some populations do anyway. And why wouldn't you then expect to match, some of their outcomes? So, being sensible about it, that's really the sort of range. Now, having said that, if someone has a thyroid condition, you might want to go a little bit more gently, but then they need a little bit of guidance. Monitor what happens with their thyroid hormone. If you do it right in a sensible way, there's no reason why. Remember, the thyroid still needs iodine to function well. But if it's done in the correct, sensible way, monitoring those people, then yes, okay, you need to go a bit more gently with those. But people who don't have a thyroid issue, certainly anywhere between those doses that we mentioned, perfectly safe to be taken on a daily basis.
Or preferably start eating more seaweed.
Or eat more seaweed, yeah. That's right. Or take kelp as a natural source of iodine, which you can buy in supplemental form.
But of course, the kelp supplements tend to have a relatively low dose of iodine.
That's absolutely true, and it's not standardized in kelp supplements either in the majority. So, I generally favour taking a specific amount of something like a Lugol's iodine. A 3% or a 5% or 12% even. One drop of the 12% will be 12 milligrams. So then you're getting a standard dose on a daily basis.
Yeah. Now, if I take larger amounts of iodine, will I start to excrete that iodine in my urine?
Yes, because that is what you do. And there's actually a test that's based on that, where you're looking at, it's called an iodine loading test, where you give people 50 milligrams, which is quite a large dose of iodine, and see how much they excrete in their urine. And if they excrete 90% or more, then they've got sufficient iodine. It's only when the body holds onto it it means your iodine suggests that you don't have enough iodine on board. So that's actually used. But what does that tell us? It means that if you take higher doses, the body just excretes it in the urine.
Mm-hmm. But it also means for a lot of people, when we take a higher dose, the body says, oh, goody, let's keep this.
That's right. If you need it, that's right. If you need it, that's right.
Yeah. How do we go about dosing omega-3 fatty acids? That sounds a bit more difficult to me.
Well, the best way with that is to actually measure something called the SIP score, which stands for Silent Inflammation Profile. What it really is, it's just the ratio. It sounds fancy. It's the ratio of omega-6 to omega-3, which you measure in blood, and it can be done in a simple finger prick test these days. There are sophisticated ways of looking at your fatty acid profile, but the key thing is, what is your omega-6 to omega-3 ratio? Ideally, that should be around 2. So 2 to 1 of omega-6 to 3. The majority of people who I've tested in the West, their ratio comes back 15, 20, even higher than that to 1. So this is quite. It's not because it's not tested. Nobody knows. They're walking around with these abnormal imbalances in omegas. To their own detriment. But the simplest way to correct it is test your SIP score, and then take omega-3s at a level to correct your SIP score to about 2, and then you've got the balance of the omegas about right if it's around a ratio of 2.
And is there some benefit in taking less omega-6s, for example, less? Sunflower oil?
Yeah, there is. So that's another way is to reduce your omega-6 intake. It tends to come from more animal foods. So if you have a diet which is high in animal foods, you will tend to get more omega-6s anyway. And that's why often we'll recommend more fish rather than meat. But you're right. So some of the oils as well are
the seed oils. So basically soya oil, sunflower oil.
That's right.
In fact, basically anything apart from rapeseed oil and olive oil are going to be fairly high in.
That's right.
In omega-6.
That's right. So that's another way, is reduce the omega-6. In my experience, though, often people will need more omega-3s to get their ratios right, because sometimes just dropping the omega-6s doesn't get the balance where it should be quickly enough.
Yeah. And I'm happy to prescribe green vegetables, a large pile, once a day, so I don't think we have any difficulty dosing that. And that's got so many benefits. We know that the nutritional effects, the microbiome effects, the reducing colon cancer effects, all sorts of beneficial effects.
Lots of correlation studies showing that if you look at intake of fruit and vegetables versus incidence of cancer and heart disease, there's a difference in 50% risk in both of those things, with the top quarter of intake of fruit and veg in a population compared to the bottom quarter. 50% difference in risk. So it's a big thing. Phytonutrients in the diet, having more of them, is definitely something we can all do to, again, reduce risk of heart disease and cancers.
Yeah. That is absolutely brilliant, Dr. Eccles. Thank you so much. As you can tell, I was taken aback by some of the things you said there. The massive imbalance that we have in omega-6s to omega-3s, I wasn't aware of that. And
Common in the West.
Yeah. And the incredible doses of iodine being ingested just routinely in Japan, for example, by eating seafood products. Even going back in our own country, we used to use seafood seaweeds very commonly as fertilizers. And then that goes into the plants, and you'd have the chickens pecking on it, and you get iodine in the eggs, but all those things pretty well gone now, unfortunately.
Yes. And actually, doctors used to prescribe iodine quite a lot. Before the advent of pharmaceutical medicine, iodine was a go-to, solution for a lot of things. But it sort of gradually took a back seat as, Big Pharma took over, and we went to, pharmaceuticals.
Now, Lugo's iodine, I believe Dr. Lugo's was a French doctor way back from the 1820s, I think. Ludicrously, you can't actually buy this now in pharmacists in the UK. Just quite incredible. You can get it online and
you can, yes,
supplements, right. But the idea that you can't walk into a pharmacist and get this time-proven wound cleaner, for example.
Yeah, that's right.
And of course, I used to be a theatre nurse, and we use iodine. We learned about the different antiseptics, and iodine kills everything. It kills fungi, it kills all bacteria, and I think it kills pretty well all viruses as well. It's just
fungi, bacteria, virus. They still use it, don't they, John? They paint it on patients pre-surgery.
Last time I was there, poverty and iodine just all over the place. Yeah,
that's right.
Absolutely, and a very small number of people are allergic to iodine or potentially the proteins in shellfish, but that's a different debate. So Dr. Eccles, you've given us some really good pointers for general health: the vitamin D, the iodine, the omega fatty acids, the green vegetables. No reason for everyone not to optimize their intakes of that, and given us some really impressive insight. Breast cancer is so common, isn't it? By far and away the most common cancer in women.
80% increase in the last 40 years. So it's we're not winning, and that we need to change what we're doing to win that battle.
Yeah, indeed. So for that, thank you very much, and we'll put links to Dr. Eccles' resources underneath this video in the top of the description as well. So Dr. Eccles, thank you very much for coming on.
Thanks, John. Thanks again. All the best.
Thank you.